Good morning. Sorry to be so loud. We're going to get started with this Quick Shots 4. We have a lot of material to get through. So just a reminder, speakers, you'll have 2 minutes to present and then 2 minutes for questions. If the questioners could limit their questions to just one each time, that would be appreciated. And we'll have the speaker who is on deck wait over there in the corner so that we can get through things quickly. Also in the middle of the session we'll have a tribute to Dr. Jens Rosenkrantz that was put together by Christina Fang from Cincinnati. So with that, why don't we get started? Our first talk is intestinal stem cells and EZH2 are involved in the pathogenesis of neonatal intestinal injury. And the presenting author is Dr. Bo Lee from Sick Kids.
Thank you. So hello everyone, I'm Bo Lee. I'm from Dr. Pierre Lab and Sick Kids Hospital. I'm honored to present my work. Intestinal epithelium is constantly renewed and regenerated, driven by the intestinal stem cells located at the bottom of the crypts and seen in pink in the figures. So in that, we have found that there's a reduction of the intestinal stem cells and a reduced intestinal epithelial proliferation. And this leads to the uncontrolled inflammation. So EZH2 acting on the histone methylation and regulate protein expressions. It has been reported that EZH2 maintain the intestinal stem cell niche, limited their differentiation, as well as regulate inflammation. So the aim of our study is to determine whether EZH2 deletion in the intestinal stem cells lead to the neck-like injury. First, we have created a model of EZH2 deletion in the IEC18 cells by transfection with EZH2 siRNA. EZH2 knockout leads to the decreased expression of the intestinal stem cells and the intestinal proliferation. Inflammation was further elevated after exposing to LPS-induced epithelial injury. And we have developed intestinal organoids, which is more closely representative of what happened in the intestine than the cultures. We have created EZH2 knockout mice intestinal organoids from the EZH2 knockout mice. EZH2 knockout decreased the intestinal stem cells and proliferation expressions in the organoids. There also increased intestinal buddings indicate less proliferation and more differentiation. Finally, we found in the EZH2 knockout mice pups that there's a reduction of the stem cells and also the proliferation. We also observed that there was increased inflammation in the EZH2 knockout mice. EZH2 knockout induced intestinal epithelial damage, which is similar to what we observed normally in neck pups. So in conclusion, knockout EZH2 in the intestinal stem cells decreased the intestinal stem cell expression, decreased the proliferation, and increased the inflammation. This leads to the neck-like intestinal injury, and these studies provide the information on the molecular mechanism of neck development and the implication for the treatment. Thank you for your attention.
Paper's open for questions. So I have one question. How do you see this tying into how we ultimately treat NEC?
Yeah, so that's a great question. That's always the question we ask first, and once we find some mechanism and how we treat it based on that. So EZH2 is the key factors, which is the link between the environment and also the intestine epithelium itself. And we have multiple ways to treat that, and such as the microbiome treatment and the nutrition treatment. And also there's another way we can use the microRNA or the link RNA, and so we can deliver the microRNA directly to upregulate EZH2 if we think it's necessary. So that's another method and we can use for the treatment. Thank you for your question.
Great. Any other questions? Great. Thank you.
Thank you.
Thank you.
Next, we'll hear about short-chain fructooligosaccharides provide intestinal protection against experimental neck. The presenting author is Haitao Zhu from the Hospital for Sick Kids.
Good morning. My name is Haitao Zhu from Dr. Pierre's lab at the Sick Kids Hospital in Toronto, Canada. Thank you for giving the opportunity to present this work. Short-chain fructooligosaccharides or scFOS is a novel probiotic with anti-inflammatory properties. Our previous study has shown that it can give beneficial effect in IBD model. scFOS can be added to infant formula, but its role in the development of necrotizing enterocolitis has not been explored. So the aim of our study is to investigate the effects of scFOS on intestinal injury in our experimental NEC model. We employed C57 Black 6 pups. Breastfed pup were used as control. We induced NEC by hypoxia, garbage feeding of hypersimilar formula, and LPS administration between post-day 5 and 9. For scFOS intervention, NEC pups received daily garbage feeding of formula with added scFOS. Our first result finding from histology is that significant mucosal injury was seen in the NEC group. The NEC plus scFOS group had less intestinal injury, showing the protective effect of scFOS on the intestinal wall. scFOS also reduced gut inflammation. In both TNF-α and IL-6, there was significant increase seen in the NEC group. The NEC plus scFOS group, by contrast, had significantly reduced these inflammatory markers back to levels similar to control. Additionally, in the NEC group, there was a significant reduction in enterocyte proliferation relative to control, and this was restored in the NEC plus scFOS treatment group. In conclusion, our study demonstrated that scFOS can protect the intestine from epithelial damage relative to NEC. This beneficial effect is associated with decreased epithelial inflammation, enhanced enterocyte proliferation in NEC. So scFOS can be a potential protective feeding supplement in units at risk of developing NEC. Finally, I want to thank my all colleagues at the PRS lab for their contribution and support. Thank you very much.
Thank you for the presentation. Any questions from the audience? You guys will need to get asking questions, or you'll get tired of us asking the questions. So what's the potential downside of this? And should we not be giving it to some kids versus other kids?
Yes. So our preliminary results showed that scFOS can have the beneficial effect on intestinal injury on NEC. So maybe it will be a potential precaution which can apply in the clinical NEC. So, but however, before this clinical application, we still have a long way to do. We should to explore its mechanism and what's the best timing for giving the scFOS before its application, clinical application.
Great. We'll take one quick question from the back.
Yeah, Mustafa Kabir from Children's Hospital Orange County. This may be self-evident, and I apologize, but in your NEC plus scFOS pups, you said you fed them formula and then gave them scFOS. Were they also induced with hypoxia and LPS? They were, okay.
So actually, in our current experiment, we give the scFOS, start giving the scFOS at the post day 5, which is the same time we giving the induced to we give the NEC induction to our pups. So our preliminary results have shown that maybe the scFOS can prevent the intestinal injury from the NEC. So, thank you.
Thank you. We'll move on to the next. If you can catch them after, we'll got to keep moving. Sorry.
Thank you.
Thank you. Next, we'll hear remote ischemic conditioning reduces the injury associated with experimental intestinal ischemia/reperfusion. Presenting author is Dr. Miyake from the Hospital for Sick Kids.
Thank you. I'm very happy to have this opportunity to present our work. Midgut bulbous is associated with intestinal ischemia reperfusion or IR injury and can progress to severe intestinal damage. Remote ischemic conditioning or RIC has been reported to reduce the IR injury in severe disease. The aim of this study was to investigate whether RIC protects the intestine from IR injury, which mimic midgut bulbous. In this study, we used 3 weeks old rats. Intestinal IR injury was obtained by 45 minutes occlusion of superior mesenteric artery, followed by the occlusion. During mesenteric ischemia, one group received leak which consists of 4 cycles of hind limb ischemia and reperfusion. That group was called remote ischemic power conditioning group. And the other group had leak just after intestinal reperfusion, called remote ischemic post-conditioning group. The animals were sacrificed 24 hours after surgery. Intestinal injury was present after IR. However, this injury was reduced in both remote ischemic power conditioning and post-conditioning groups. Expression of inflammatory cytokine IL-6 was lower in both remote ischemic conditioning group compared to IR alone. Similarly, myeloperoxidase activity was significantly lower in both power conditioning and post-conditioning groups. These results indicate that leak can reduce inflammatory response caused by IR injury in intestine. In addition, carbonate protein was also significantly lower in both leak groups, indicating lower oxidative stress. In conclusion, remote ischemic conditioning attenuated intestinal injury, inflammation, and oxidative stress in experimental model of intestinal ischemia reperfusion injury. Remote ischemic conditioning can be useful in children with midgut bulbs to reduce intestinal injury. Thank you for your attention.
Thank you. It's now open to questions.
Mohammed Imran, Corpus Christi, Texas. Thank you for that wonderful study. The question, NEC is on everybody's mind, I guess, from the last presentations. Have you looked into the effect of preventing perfusion injury from NEC or ischemia from NEC using this technique?
Actually, yeah, we previously reported the effect of leak in our experimental model of NEC. So it has some beneficial effect on our experimental model of NEC. Yeah.
Any other questions? All right. Thank you.
Thank you.
Next, we'll hear pharmacologic toll-like receptor TLR4 inhibition in traumatic brain injury attenuates neuroinflammation and improves cognitive outcomes by promoting monocyte infiltration. Presenting author is Dr. Young Chun from Johns Hopkins.
Excuse me.
Yes, green to advance.
Okay, great.
Let me bring up the next slide.
Good morning. So our lab, Dr. Nasser and Dr. Hakim's lab, have been interested in TLR4 and the immunology and the traumatic brain injury. We know that the tissue damage from traumatic brain injury leads to release of damage-associated molecular patterns, which induces robust inflammatory response. And we thought that the TLR4 may be a link between the two because it's able to bind these molecular patterns called DAMs and also induce inflammation after once it's activated. And therefore, we study this by looking at TLR4 signaling and use these different mice that are available in Dr. Hakim's lab, which included TLR4 knockout mice, conditional microglia knockout of TLR4, as well as in vivo pharmacologic TLR4 inhibition using C34, which again has been developed by Dr. Hakim. And we used a model called the control cortical impact model, where we do a craniotomy, hit the mice brain, and study the effect using multiple testing at different time points. And we came up with a number of different interesting findings. We saw that the pharmacological inhibition of TLR4 led to global cytokine expression of both pro and anti-inflammatory cytokines when the TLR4 is inhibited using C34. And this led to improvement in new behavioral outcomes in the mice that are treated with C34. We also found that on post-treatment day 7, there was an increase in infiltrating monocyte population in the mice that are treated with C34 and had better neurobehavioral outcomes. We're just beginning to understand why and how these infiltrating monocytes are beneficial when we do cell sorting experiments. We separate out the microglial cells and the monocytes into these little test tubes so that we can study them individually. And we saw that the infiltrating monocytes may have a more anti-inflammatory profile, and it showed that it has a decreased amount of pro-inflammatory cytokines such as interleukin-6 and TNF-α, but had increase in the amount of interleukin-10 cytokine expression at different time points. So we'd like to conclude that the TLR4 signaling pathway plays an important role in initiating the TBI-induced immune response, and the pharmacological inhibition of TLR4 signaling pathway using CD34 leads to global cytokine suppression, and selectively knocking out TLR4 from the microglial population that had no effect on inflammation. And the CD34 treatment increased the infiltrating monocyte population, as well as the one-day CD34 treatment improves neurobehavioral outcomes. And this may be attributed to the increase in the more anti-inflammatory infiltrating monocyte population. And thank you.
This paper's now open for questions. So I have one. I mean, this is an exciting and obviously important for brain-injured kids that we see all the time. Any thoughts at this stage? I know it's early on. Would this be given, immediately on arrival to the trauma bay, or when would you start doing it?
So currently our model is that we have to have this C34 compound given the prior to sort of preempt them to the effect. We're currently looking at giving them IV immediately after, and we're trying to see if that has the same similar effect currently. But unfortunately, with the IP injections, they take a little longer to take its effect, so we are needing to give them prior to the injury to see any effect.
Great. Thank you.
Next, we'll hear human hepatic progenitor cells generate tissue-engineered liver comprised of major hepatic cell types in a 3-month murine model. And the presenting author is Dr. Anthony Squilaro from CHLA.
Thank you for the opportunity to present our work. We have no disclosures. Liver failure is morbid and fatal. And although transplantation has improved patient outcomes, donor supply remains a major obstacle. Alternative approaches with cellular therapies have emerged with tremendous potential to help patients, particularly those with congenital metabolic disorders. We've previously developed tissue-engineered liver from human liver organoid units as well as pluripotent stem cells. However, in order to meet standards for future cellular therapies, we hypothesized that evolving our hepatic progenitor protocol into a scalable suspension system might improve this source to generate tissue-engineered liver. Adherent iPSC cells are lifted into suspension into scalable vessels and then taken through 17 days of direct differentiation to 3D spheroids. These day 17 hepatic progenitor cells are then seeded onto a biodegradable scaffold and implanted into the omentum and the subcutaneous tissues of a non-skid mouse. And after 6 weeks and 3 months, telly is harvested. And as you can see in the H&E on your far right, epithelial structures with a central lumen develop, resembling biliary epithelium, as indicated by the black arrow. And vascular incorporation in the graph can be seen by the endothelium filled with RBCs, indicated by the white arrow. At 6 weeks, telly contains hepatocytes, as identified by mature hepatocyte marker albumin in green. And these are found alongside another hepatocyte marker, HNF4 alpha, in gray. The other predominant cell type, cholangiocytes, are also seen in red by CK19 positive cells. At 3 months, we also see hepatocytes, as identified in the top 2 immunofluorescent pictures by hepatocyte-specific antigen marker, HSA in green. And the bottom 2 immunofluorescent panels, we see, again, CK19 positive cells forming ductular structures, indicating cholangiocytes. Human nuclear marker lamin, as well as cytoplasmic marker mitochondria, confirm that the donor population is human in origin. And interestingly, if you look at the ELISA graph to your right, those mice that had telly implants have the presence of human albumin in the host non-skid mice serum, indicating that there's a functional component of tissue-engineered liver that develops. In summary, hepatic progenitor cells can be generated from an iPSC line in a scalable suspension system, and the telly that's subsequently generated at about 6 weeks and 3 months contains the predominant liver cell types, both hepatocytes and cholangiocytes, and there's a synthetic production of human albumin in the host non-skid mice serum. And further enhancement of these protocols may recapitulate even more functions of the native liver. I'd like to thank my mentor, Dr. Tracy Grickscheid, as well as my other lab members, and I'll take any questions at this time. Thank you.
Thank you. Paper's open for questions. Question in the front.
So would you see this in future models being used in a similar way as the mouse model, putting in the implant into the omentum and recapitulating some of the functions of the liver that way?
Yeah, thank you for your question. The major difference, I think, with this model that we've been sort of going towards is that we implant these in the omentum, but we also implant them subcutaneously. And the goal is that one day we could restore native liver function by having grafts that we can have surveillance over just under a subcutaneous pocket. Traditional, or what's been previously described in liver cell transplantation or conventional liver cell transplantation, is actually taking donor liver cells called primary hepatocytes, isolating them from donor livers, and then implanting them in the portal vein. But it's a more invasive procedure. Thank you.
All right. Thank you very much.
Thank you. Next, we'll hear autologous transplantation of skin-derived precursor cells in a porcine model. The presenting author is Dr. Jordan Taylor from Stanford.
All right. Thank you for the opportunity to present our work. We have no disclosures related to this. So Hirschsprung disease, as we know, is characterized by the arrest of migration of neural crest cells causing a distal aganglionosis. It affects 1 in 5,000 live births. Surgery is the mainstay of therapy, though it's highly morbid with high rates of complication. Our lab has been looking into alternative cell-based therapies for Hirschsprung disease. We know that skin, particularly the dermal layer, contains stem cells derived from neural crest. These cells can differentiate into neurons and gliocytes in vitro, and we've recently shown in a rodent model that transplanted skin-derived precursor cells can generate enteric ganglion-like structures in vivo. So the aim of this project was to translate this to a large animal model using non-invasive procurement of the skin and an autologous transplantation of these skin-derived precursor cells, or SKPs. To do this, we used a mini Yucatan model. Skin was procured from the forelimb shoulder. We used benzalkonium chloride as a chemical denervation agent in an isolated segment of colon. The skin was then cultured in a neuroglial selective media, and on postoperative day 7, the cells were fluorescently labeled as well as marked with India ink prior to injection into our aganglionic colon segment. The animals were sacrificed 2 days later. When we looked at the cells at the time of injection, we found that cells were expressing both P57 and nestin, two very specific markers for neuroglial progenitor cells of the neural crest origin. In vivo, as I said, we identify these cells using both India ink and a red fluorescent dye. When we looked again at the P75 and nestin markers, we saw that there was a co-localization with our injected cells. We also noted that these markers and these cells formed a cluster that does resemble a ganglia. So in conclusion, we have demonstrated that these SKPs, these skin-derived precursor cells, demonstrate neuroglial progenitor phenotype, and we believe that this autologous SKP transplantation could be a potential cell-based therapy for patients with colonic Hirschsprung disease or other motility disorders. In the future, we hope to continue to track these cells in a more long-term fashion. We also hope to restore, in our model, restore continuity so that we can measure functional outcomes such as motility or absorption. Thank you, and I'm happy to take any questions.
Thank you. This paper's open for questions. We have someone coming up. Please remember to say your name and where you're from.
Yeah, thank you very much for your presentation. Oscar Gomez from Spain. Do you have chance to track the movement of the cells due to in the real situations? The ganglia has the craniocaudal, the evolution. So you have to track the movement of the cells you implanted?
Are you asking if we've been able to track just in our own model, to track the aganglionosis? So we have. So in our model, when we do this benzalkonium chloride, we're able to achieve aganglionosis up to about 60 to 70% of the ganglia or disappear after this treatment. It is a pretty toxic treatment, so we've had to adjust and modify that to essentially hit an acceptable level.
Okay. Thank you.
Thank you.
Thank you. All right. Next, we'll hear identification of a novel CIRP receptor and its role in sepsis. Presenting author is Dr. Naomi Lisa Denning from Cohen Children's Medical Center at Hofstra, Northwell.
Good morning. We have nothing to disclose. Extracellular cold-inducible RNA binding protein, or ECIRP, is a pro-inflammatory protein that is secreted extracellularly in times of cellular stress, such as occurs in sepsis. Triggering receptor expressed on myeloid cells 1, or TREM1, is an activating pro-inflammatory cell surface receptor. We propose that ECIRP binds to TREM1 in macrophages to stimulate inflammation. Among other modalities, we demonstrated binding by first confirming co-localization. Macrophages were stimulated with CIRP, fixed, and then stained with antibodies against TREM1 in red or ECIRP in green. Co-localization is demonstrated by the yellow color in the merged image. Fluorescence resonance energy transfer, which generates a positive FRET value by measuring changes in energy emission when two molecules bind, demonstrated binding between TREM1 and ECIRP. Now that we've established interaction between ECIRP and TREM1, we developed a small 7-amino acid peptide called M3 that inhibits this ECIRP-TREM1 interaction. M3 is derived from the amino acid sequence of CIRP, and as you can see, it inhibits a positive FRET between TREM1 and CIRP. We first tested the ability of M3 to inhibit TNF-α production in macrophages. CIRP stimulation of raw cells resulted in significant increases in TNF-α levels in the supernatant, and M3 was able to dose-dependently inhibit this. Two control peptides were unable to do so. This is a busy slide, but you can see that in vivo, 20 hours after sepsis induction with cecal ligation and puncture, serum and lung markers of organ injury and inflammation were significantly elevated, and M3 was able to mitigate these increases. Moving to survival studies, M3 improved survival in 2 murine models of sepsis. M3 rescued mice from endotoxemia, and in a more clinically relevant model of polymicrobial sepsis with cecal ligation and puncture, M3 significantly improved survival from 45% in the vehicle group to 80% in the treatment group. So in conclusion, we've demonstrated that ECIRP binds to TREM1, and inhibiting this interaction improves outcomes and survival in sepsis. Thank you.
Thank you. Great presentation. It's open for questions. Told you guys you're going to make me ask questions. I mean, this is a great model, and obviously we heard all week about sepsis being a huge problem for all of us. When would you give this? As soon as you sense the patient has sepsis?
So in these experiments, we gave it at the time of sepsis induction, but obviously that's not very clinically applicable. So some of our next steps include giving it at a later time point and giving multiple doses and seeing if you are able to demonstrate further improvement.
Great. All right. Any other questions? All right. Thank you.
All right. Next, we'll hear fetal enzyme replacement and stem cell transplantation rescue brain microglia in murine mucopolysaccharidosis type 7. Presenting author is Dr. Nguyen from UCSF.
Thank you very much for the opportunity to present. We have the following disclosures. Our group is very excited for molecular therapy as a new frontier of pediatric surgery because it can greatly expand the number of diseases that can be treated. The model we work with is called SLY syndrome. It's a severe lysosomal storage disorder where most fetuses would develop hydrops and die before they're born. Those that do survive have severe mental retardation and as well as other systemic problems. Since this results from a single missing enzyme, postnatally we can simply replace that enzyme or supplement with stem cells that will produce enzyme. However, a main limitation of postnatal treatment is the presence of the blood-brain barrier, thus making the neurologic symptoms difficult or impossible to treat. Our hypothesis is that a prenatal application of these two treatments could bypass this limitation. Last year we presented on some phenotypic benefits of in utero enzyme replacement. I'll focus on our brain studies for this talk. We're really focused on the microglia as the key cell to correct because they are the storehouses and producers of this enzyme and the key immune modulators in the brain. We found first by total brain homogenate that enzyme was able to penetrate with in utero treatment but not postnatal treatment. And when using flow cytometry, we saw that the microglia were able to be penetrated in most cases. Now that we see that enzyme got in, we turn to functional studies. With immunohistochemistry, we saw severe inflammation in SLY syndrome brains, which was partially rescued with enzyme treatment. Here's a video demonstrating some of our mice. On the left side, you'll see untreated SLY syndrome mice. They're slow, they look autistic, and they're not moving. And on the right-hand side are the same mice that have been treated, and they appear almost indistinguishable from wild-type mice. We then moved on to a more durable source of enzyme, reaching for stem cells, and found using a GFP marker that in most cases a fetal approach did penetrate the brain and adopt a ramified microglial morphology. We then sorted and sequenced these cells and found that they indeed became microglia after engrafting. Turning again to functional studies, we used CD68 staining. We again found severe inflammation, but in the center of the slide you'll see that there are areas that were spared. And looking at GFP signal, this is exactly where our donor cells had engrafted, indicating that they can cross-correct their neighboring cells. To summarize, both of these therapies can penetrate the brain with a fetal approach, and in utero stem cell transplantation can engraft as microglia and treat this disease long term. And this is applicable to other lysosomal storage disorders with neurologic component as well. Thank you, and I'll take any questions.
Thank you. This paper's open for questions. First mic.
Mohammed Imran, Corpus Christi, Texas. This is a very, very elegant study. The fetal surgery obviously is not without its own risks. So the question is, have you tried at all the intranasal application to get the migration of the neurocytes up the olfactory nerve? Because that's been shown to allow migration across the blood-brain barrier.
We have not, and thank you for that question. Postnatally, what people have done is after radiation chemotherapeutics, you can get your cells in through the nose. But fetally, we found that the safest access is through the umbilical vessel, as has been done for in utero transfusions. So to us, this represents a less invasive and more traditional way of introducing our stem cells. Thank you for that suggestion.
We have time for one more question.
Matt Grant, WashU St. Louis. Really good work. You guys are doing this injection at what time point, and are you giving the enzyme and stem cells simultaneously?
Thank you. That is a really great question. In our enzyme studies, we found that these mutants, these SLY syndrome mice, don't survive without an enzyme injection in utero. And so, yes, with the stem cells, we do give enzyme to keep those mice alive during the time that the stem cells can expand and do work. Because it's been shown that it can take up to a month or longer for these cells to expand and improve disease. And we inject both at around E13 as our target time, because at E14, the blood-brain barrier starts to close.
Thanks.
Thank you.
Thank you.
Now we'll take a short break and watch this video, which is a tribute to Dr. Jens Rosenkrantz. It was put together by Dr. Christina Fang, who's the fellow at Cincinnati.
Now, when I was there, Rosenkrantz was functionally just working in the lab, and he was an interesting guy because he was very research oriented, which is part of the reason why the surgical section has this research award they give out every year, and it's called the Rosenkrantz Award, named after him, and it's partly because of his commitment to research and the fact that he was really truly a research oriented person.
He was the only really full-time pediatric surgeon in children's there were about. Willie was an attending at that time. He wasn't full-time. He was a good teacher. He loved teaching. He loved making rounds. And he was also a Hale Fellow, well met. He was a smoker and a drinker, and he was a really fun guy to be around. He was very involved with all of the teaching conferences. He was a trained thoracic cardiovascular surgeon.
He was a very interesting man. First of all, he was obviously a dedicated pediatric surgeon, an extremely bright man. Okay. Maybe one of the outstanding things he did was that although there was a lot of research being done in pediatric surgery, a lot of it was clinical. And Jens was a very bright, as I said, mathematically inclined individual who really wanted to apply his math skills and computer science to research, basic research in pediatric surgery.
Most of those old goats that trained back when Rosenkrantz did also did some cardiac surgery, or they had some cardiac surgery experience, because he was very interested in cardiac physiology, and so he was really interested in the idea of doing ECMO. And at that point, there were only probably between 10 and 12 active places in the world that had tried to do ECMO or had ever established a program. And Jim was very supportive and pushed pretty hard with me to say this is something that we should be doing.
Push the boundaries of people in pediatric surgery to look at basic research as an important component and not just clinical research. And so I think that was probably his outstanding characteristic, was that he just had the intellectual capability and the determination to follow into this, and he influenced people around him to go ahead and do basic research as well.
Thanks again to Dr. Fang and Dr. Falcone for that great video. We'll jump back into it. Next, we'll hear association of blood component ratios with 24-hour mortality in injured children receiving massive transfusion. The presenting author is Dr. Jonathan Groner from Nationwide Children's Hospital.
Thank you. This is the work of Dr. Butler, who could not travel here today for the meeting. So this is really all her work, not mine. So we're going to talk about massive transfusion. This is obviously an important part of the damage control resuscitation, because hemorrhage is an early cause of preventable death and trauma. We used a TQIP database, and we looked at kids who were under 15, so less than or equal to 14 years old, who received the massive transfusion protocol. We excluded patients who basically died early, had unknown outcome, or had no blood in their resuscitation. We were able to divide this group of massively transfused patients into 3 groups based on their plasma, so fresh frozen plasma to packed red blood cells and platelet to packed red blood cells. You can see the 3 ratios are shown there. We used multiple imputation and multivariable regression analysis. This complicated scheme basically shows how the database has almost 124,000 children in it, of which about 590 were massively transfused. We were able to break it down into these low, medium, and high groups with reasonable numbers in each group. This is the most important slide of the presentation. You can see that when patients had higher levels of fresh frozen plasma to packed red blood cells, the mortality went down. So both the medium and high groups had reduced mortality, and the platelet to packed red blood cell ratio did not result in any change in mortality. So to conclude, higher plasma to packed red blood cell ratios of at least 1 to 2 likely reduce mortality. There is not a clear relationship between platelets and packed red blood cell levels, and obviously further prospective studies are warranted to see if this finding can be validated. Thank you.
This paper's open for questions.
Dave Nitriga, Phoenix. So were you able to look at when they got their fresh frozen plasma in relation to mortality? And did you notice any changes or breakpoints in age at which the ratio was not protective or was more protective?
Thank you. Two great questions. I think the database is not robust enough to allow the answer to the first question, the timing, and the second question is sort of subject to further analysis that I obviously couldn't squeeze into my 2-minute presentation.
Other questions? I think we have someone coming up.
Hello, nice work. I would like to ask if you use a tranexamic acid.
So that's a great question. There is no TXA usage in this study, and usage, I mean, just in our local trauma center is highly variable in Ohio. So again, this involves a process of translating the adult data to our data, and anybody was last at the most recent trauma critical care in Las Vegas, it seems like the sun is sort of setting on TXA, like it really peaked and now it seems to be declining. So we do not use that.
All right, thank you.
Thank you.
Our next talk is Secondary Over Triage in a Pediatric Level 1 Trauma Center. Presenting author is Dr. Andrew Norden from University at Buffalo.
Good morning, and thank you for the opportunity to present our work. And we have no disclosures. So the American College of Surgeons Committee on Trauma prescribes maximal under and over triage rates of 5% and 35% respectively. However, few studies have examined the phenomenon of secondary triage or the transfer of trauma patients. Adult research estimates that potentially preventable transfers account for between 7% and 24% of all transfers. And pediatric trauma patient transfer rates range from 22 to 27%. We therefore sought to examine this phenomenon in our own Level 1 pediatric trauma center. We performed a 3-year retrospective review of all trauma activations at our pediatric Level 1 trauma center. Burns and non-activated traumas were excluded, and we collected the data points listed here. Based on previous literature, we define secondary over triage as an injury severity score less than or equal to 9, a length of stay under 24 hours, and to include no requirements for ICU admission or operative intervention. We compared secondarily over triage patients against all other trauma transfers and against similar patients arriving from the trauma scene directly. We identified a total of 1,789 trauma activations, of whom 753, or 42%, were transferred. Of these patients, 335, or 44.5%, met our definition of secondary over triage. Secondarily over triage patients had a higher GCS, but traveled a shorter average distance relative to other transferred patients. When compared against patients arriving directly from the trauma scene, secondarily over triage patients were more likely to be Caucasian and had a higher injury severity. Furthermore, these patients were significantly more likely to be admitted from the emergency department, thereby incurring greater hospital charges. Our results confirm those of previous studies demonstrating that secondary over triage contributes to potentially unnecessary hospitalizations and increases in patient charges. This represents an opportunity for trauma systems to improve the transfer process and for individual centers to both educate referring hospitals and to examine and optimize their own activation criteria to provide the greatest value for care. Thank you, and I'll take any questions.
All right, this paper's open for questions. So I'll ask a question. So we all of us at Level 1 Trauma Center see a lot of kids come that we question whether they're over triage, but I think we also think there's benefits to some of those kids from the other cares, not just the surgical care that they might get, the instructions, the orthopedic specialty care. Did you look at that in your analysis versus just the ISS cutoff and the length of admission?
We hadn't looked at that in our initial analysis. So many of the other studies examining secondary over triage, both in adults and in children, look at all trauma transfers. And because we do agree that there is a value in pediatric trauma patients being treated in pediatric trauma centers and being transferred when appropriate, we looked specifically just at activations, then to also comment on activation criteria and their appropriateness.
Great. Any other questions? All right, thank you.
Thank you.
All right. Downward trends in pancreatectomy of moderate and severe blunt pancreatic trauma in children. Presenting author is Dr. David Notrika from Phoenix Children's.
Thank you. It's my honor to present here. This is work done at Phoenix Children's Hospital. We have no disclosures. We looked at the 2000 to 2014 national inpatient sample hiccup data, and we queried for patients who had pancreatic injuries that were less than 18 years of age. We used ICD-9 codes. What we found was about 6,500 injuries, and about 500 of those injuries were greater than or equal to grade 3, 67% male with a median age of 11. The overall mortality was about 4%, and about 13% of those patients underwent pancreatectomy. What we saw when we evaluated the data for time trends is that the severity wasn't changing much over time, but we did see a decrease in the rates of pancreatectomy over the 15-year time frame. The mechanism of injury was really trimodal, with non-accidental trauma on the right being the most common in the younger patients, and then bicycle accidents in the middle age, and then older kids being injured through motor vehicle crashes. When we look at the pancreatectomy characteristics, what we see is that the rates are declining more for the moderate and severe pancreatic injuries, and very little for the patients with the minor injuries. And the decline that we saw is mainly driven by a decrease in the distal pancreatectomies for patients with high-grade injuries. ERCP declined a bit during the course of the study from about 2.5% to around 1%, and MRCP is used very infrequently with a percentage of about 0.4%, but increased to almost 0.6% by the end of the study. The rates of death did not change during the course of the study, and the length of stay increased slightly during the 15-year period. In conclusion, blunt pancreatic injuries are uncommon, and the data suggests that we're seeing a decrease in the number of pancreatectomies being done, and it's largely being driven by a decrease in the number of distal pancreatectomies for patients with greater than equal grade than grade 3 injuries. There's very significant year-to-year variability, and this study, of course, is subject to all the limitations of the national inpatient sample, including rare sampling events and inconsistency with coding. Thanks.
This paper's open for questions. Question back.
Hi, I'm Gwen from Los Angeles. The question is it really did you actually look in terms of the length of stay for those subgroup of patients who were treated with pancreatectomy versus those treated non-operatively?
Yeah, so what we presented in this data is the total length of stay by the cohorts, as opposed to breaking it down between operative and non-operative. The problem that you have with this type of large data set is that you can't distinguish very well between patients who had non-operative management and failed and those who had initial operative management. And so you've got a little bit of an analysis problem in this type of data set.
Yeah, so for that reason, I do think that with the problem with the database like this, and then really it did not answer the questions in terms of how the patient is doing. Just because you chose not to operate doesn't mean that it's probably the best form of treatment, right?
No, I agree. We are, believe me, I'm a strong advocate of operating on these. We were surprised to see the rates of surgery going down so significantly.
Let me take one quick question.
Aaron Jensen, UCSF. Just curious, last I checked, there's no ICD-9 code for laparoscopic pancreatectomy. How did you deal with that? And could it be that most of these are being done laparoscopically now and we're just not picking that up?
So that's an excellent question. We spend a tremendous amount of time coding data and putting ICD-9 codes in and putting these into administrative databases. And then when you go to try and find meaningful information on these, it's definitely a challenge. We were able to use the ICD-9 codes to based on what they should have been coding for the laparoscopic appendectomies, but I can't guarantee you that they're coding it correctly.
Yeah, I think that's one of the challenges with this.
Yeah.
Thank you.
Thank you.
All right, now we'll hear Identifying Populations at Risk for Child Abuse, a Nationwide Analysis. Presenting author is Dr. Hallie Quiroz from University of Miami Miller School of Medicine.
Thank you to APSA for allowing us to present our work. I have no disclosures. Child abuse is a major public health crisis. 700,000 children every year are abused in the United States. 1,500 of these children die every year due to abuse. Around 35% of abused children had been seen in the ER and then were missed and then ended up coming back into the ER. So victims are often hiding in plain sight, including in the hospital setting. Our objective then was to identify characteristics of hospital admissions to admissions for child abuse. Our methods, we use a nationwide readmissions database. This is an HCUP database that allows for looking through, follows patients through multiple admissions throughout a calendar year. We queried the 2010 to 2014 for pediatric admissions for child abuse. Our outcomes were for prior admissions and diagnoses before their child abuse admission, and statistical analysis. So we identified in the study 31,153 child abuse admissions. The large majority of this cohort was due to physical abuse, 15% was due to neglect. We then looked at the past admissions and found that 11% of these children had past hospital admissions. 31% of these had multiple past admissions. 37% had past admissions to a different hospital than their child abuse admission hospital. We also looked at abuse type versus the admission to a different hospital and found that physically abused children were more likely to have past admissions at different hospitals. We then looked at past admission diagnoses and discovered that 60% of these children have chronic conditions such as psychiatric disorders, IBD, etc. 12% had had traumatic injuries in the past, 48 of those being orthopedic and head trauma, and acute infections made about a third of the cohort. We then looked at the differences between their diagnoses and the eventual abuse that they would sustain. The children that would eventually be admitted for neglect ended up having a correlation with acute conditions. Similarly, the children with eventual physical abuse ended up having past traumatic conditions, and then similarly, the chronic conditions had correlation with sexual and emotional abuse. And similarly, we did a subgroup analysis of psychiatric conditions since this was so prevalent in our population, and they also had a correlation with sexual and emotional abuse as well. So in conclusion, we uncovered a hidden population of children with past admissions, especially chronic and psychiatric diagnoses that are significantly associated with certain types of abuse. Physically abused children are more likely to have past admissions at different hospitals, so we need to improve communications between hospitals to increase detection. And then future studies are needed to improve measures to accurately identify at-risk children. Thank you. I'll take any questions.
Great work. We have time for one question.
John Groner from Columbus, Ohio. Great work. My question is, are you able to look at ethnic backgrounds and race? Because there's other data shows that white kids are a lot more likely to be missed, actually.
Right, yeah. So actually, as opposed to the KID database where you can look at racial differences, the NRD actually does not break down, racial components of that. So that would be a weakness of the NRD.
All right.
Thank you.
All right, thank you.
And bringing us home with the final presentation, the effect of a teddy bear hospital project on children's anatomical knowledge, anxiety, and medical student professionalism. Presenting author is Julia E. Mildenberger from University Medicine of the Johannes Gutenberg
University in Mainz, Germany. Good morning. My name is Julia Mildenberger, and I'm a senior medical student of the University in Mainz in Germany. Today I would like to talk to you about our research on our Teddy Bear Hospital project. The Teddy Bear Hospital is a project where medical students provide care to toy animals of kindergarten children as an educational activity. We in Mainz organize once a year one of the biggest teddy bear hospitals in Germany. It is visited by around 1,400 kindergarten children. These children and their toy animals are attended to 120 medical students in the role of teddy dogs who simulate a medical interaction by treating various diseases of the children's toys. Our goal was to assess the effects on the medical students' professionalism and the effects on the children's medical knowledge and their anxiety towards hospitalization. The children's parameters were measured 2 weeks before and after the visit of the teddy bear hospital as an intervention by playing a memory card game about a healthy lifestyle and an anatomical puzzle, and by scoring their anxiety on a 6-point Likert Smiley scale. We also assessed the medical students' professionalism twice to that questionnaire. At least 61 kindergarten children with an average age of 6 years and 16 medical students with an average age of 24 years participated. We found a significant enhancement of 1.4 point in the memory card game, as well as 5.1 point in the puzzle, as well as a decrease of 1 smiley towards anxiety. In the medical students, we found a significant increase of 4.2 points in the self and 4.7 points in the observer assessment. In conclusion, we found many positive effects by participating in the teddy bear hospital. Therefore, this project should be offered to even more medical students and kindergarten children in medical academic centers worldwide. Thank you.
Thank you. That was a great presentation. Any questions? So how do you think we can use this just in general moving forward at all of our hospitals?
I think that is an effective preventive tool to bring knowledge not only to the children, through to also in the families. So imagine when we taking knowledge to that child, which impact it would have to take that in the families, and that would explore and argue. So we also can create a foundation stone in a reliable patient and doctor relationship.
Great. All right, thank you. Thank you all to all the presenters of this session.